This presentation is about shock, and as we go through it, we'll focus more on septic shock in this unit. I want to begin by saying that the word shock is another way of saying circulatory collapse. So it's very important that you understand and think about it. When you think of a patient who's in shock, what they are experiencing is circulatory collapse. Homeostatic regulation is maintained primarily by the cardiovascular system, and it depends on these four physiologic components. Number one, we have to have sufficient cardiac output to meet the bodily needs. Second, we need sufficient blood volume and blood pressure to maintain adequate blood flow. And on this side, we see the third component, and that is that the tissues are able to extract and use oxygen. Oxygen must be delivered through the capillaries, and the tissues must be able to extract and use that oxygen. The fourth component is we must have an uncompromised vascular system. In other words, the circulatory system must be intact. There should be no breaks within that circulatory system. As we said, I have my cat here. The vascular system is a circular and closed system, whereas the lymphatic system is an open-ended system. Fluids and macromolecules and cells are extravasated from blood capillaries, and that's what enters the lymphatic capillaries in the peripheral tissues and then transported via the larger collecting lymphatic vessels and the thoracic duct back to the blood vascular system for recirculation. Come on, Harley. Oh. So when tissue perfusion is inadequate, normal cellular metabolism cannot be maintained. If inadequate tissue perfusion is severe enough or of long duration, hypoxia and cellular death occur. Syndrome means a cluster of signs and symptoms. There is impaired tissue perfusion, which leads to cellular dysfunction. So shock is more than just low blood pressure. Although the actual incidence of shock is very difficult to track or identify, and the reason for that is because people will report shock in many different ways. But when a person is in shock from whatever the cause may be, not enough blood or oxygen is reaching the body's organs. If shock lasts more than several minutes, the lack of oxygen to the organs starts to damage them. If shock isn't treated quickly, the organ damage can become permanent and the person can die. While this picture is very pretty, in truth, what's occurring in the microvasculature during shock is very ugly. So this picture, although very brightly colored, is showing a devastating condition. In severe shock, the microcirculation changes dramatically. These changes are mainly due to a cytokine storm induced by extremely severe tissue ischemia or directly by a pathogen. So I want to go through these changes that occur one by one. There's 4 changes that I'm going to talk about. I want you to always come back to this lovely picture because this is what shock is. It's down in the microcirculation where we cannot see what is occurring, but we certainly can assess what is occurring in this patient's body, not only by assessing perfusion and vital signs. Those would be some key assessments that would help us figure out if our patient is in shock. Okay, let's talk about the first changes that occur. Number one, the endothelium is activated. Okay, you see in the picture, the pointing to the activated endothelium, and that means that the endothelium vasodilates and it becomes procoagulant and it expresses adhesion molecules. Okay, so this is not a good scenario at all, because in fact we would like red blood cells carrying oxygen to move freely one by one in a single file through these capillaries. But this situation prevents perfusion from occurring. Number two, we see monocytes. Remember, this is a type of white blood cell. They are activated as well. And when they are activated, they discharge numerous cytokines. And in this picture, the cytokines are represented by all different colors of molecules there. Purple, yellow, red, orange. They have all these different colors, but they are representing the cytokines that are secreted by the monocytes. And I especially find this interesting at this time in history, because with our COVID patients, we are discovering that they do undergo a cytokine storm, and that is what they are referring to. And now again, you'll see how coagulation and perfusion come into even our most recent pandemic with our COVID patients. And number three, we have white blood cells that are obstructing some of the capillaries. They're up there in blue in the picture. So we see white blood cells. They look like segmented neutrophils. They are plugging up the capillaries. Okay. And finally, number four, we see disseminated intravascular coagulation. That's DIC. And platelet aggregation as well. And this plugs up the microcirculation. One other thing I need to point out on this picture, and that is the leaky endothelium that you see down in the right-hand corner of the picture. During this, when the endothelium is activated, and we have the vasodilation that occurs, the typically tight junction between the capillary cells is interfered with. Okay, it becomes widened so that fluid that's normally inside the capillaries is able to move out into the tissues. So we have a leaky endothelium. We frequently talk about this concept and it's described as increased capillary permeability. So when you're reading in your textbook or other sources and you see the word increased capillary permeability, this is exactly what they're talking about, this leaky endothelium as represented in the picture. When there's so much deterioration to the microcirculation, perfusion to the organs worsens rapidly. And as a consequence, systemic shock also worsens extremely rapidly. And so this picture, while cute or beautiful in my eyes, this person is very close to the end. Okay, this is a bad scenario right here. Now, shock is classified in many different ways. This slide tells us that it's classified by the vascular tone, the intravascular volume, and whether or not the heart pump itself is functioning. Okay, so I would like you to list under vascular tone, we see that one type of classification for shock is distributive shock. So right here next to distributive shock, I want you to write the 3 types of distributive shock that we will eventually talk about in this course. The first one is septic. The next is anaphylactic, and the third is neurogenic. So for your purposes and doing well on exams, it would benefit you to memorize the 3 different types of distributive shock. And then we'll talk about distributive shocks, and you can understand that that applies to all 3 of those types: septic, anaphylactic, and neurogenic. And we will also talk about intravascular volume. This type of shock in particular, we'll discuss hypovolemic shock. And then another type of shock would be cardiogenic shock, which is heart pump failure. And we will talk a little bit about that as well. At this point, the presentation pretty much follows your textbook. So I'm going to begin. We're going to talk about the pathology of septic shock, beginning with the term sepsis. And I should say not just the term, but the condition sepsis is a leading cause of death in non-coronary intensive care units. Okay. SIRS can occur as a complication of virtually any infection of any body tissue. Severe SIRS, and SIRS stands for Systemic Inflammatory Response Syndrome. Severe SIRS response can lead to sepsis. Patients with sepsis are very ill. They require attentive monitoring and rapid intervention. Here is a diagram of the pathology of sepsis and septic shock. Okay, you'll see that it begins with a source of infection anywhere in the body. Any tissue can be involved. And then this bacteria, we're going to say bacteria, invades the bloodstream. Then we have the leaky endothelium as tissue leaks out of the capillaries, out of the blood vessels into the tissues. We have poor perfusion to our vital organs, including the heart itself, the kidneys, the liver, and the lungs. Okay, so then we start to have organ dysfunction, and one by one, successive organs fail, and this leads to death. Septic shock is an overwhelming infection. It's more common in infants and elderly and any patient population with a suppressed immune system. The primary cause of septic shock is gram-positive bacteria, such as staph and strep. But we can also see other causes, including gram-negative bacteria, such as E. coli, Pseudomonas, and Klebsiella. We can even have fungal or protozoan infections that lead to septic shock. So the first classification of shocks we're going to talk about is the distributive shock. And that is because septic shock is an example of a distributive shock. But understand that this slide does reflect the other 2 types. The same thing is occurring in these other 2 types, which we said were anaphylactic and neurogenic shock. But because we are talking about septic shock right now, know that septic shock is a type of distributive shock. And this is what is occurring in distributive shocks. There is peripheral vasodilation. And we could actually say that there's widespread vasodilation. Okay? And that subsequently leads to a maldistribution of blood flow. This leads to a relative hypovolemia. In other words, there's more space in which to put the same volume of fluid. So it appears that we have a hypovolemia, but we have not lost blood volume. Okay, we don't have any bleeding going on. We haven't truly lost volume, but we have a relative hypovolemia as a result of that widespread peripheral vasodilation. Okay. We also have these leaky endothelium, and in the capillaries we are losing fluid into the tissues. This causes edema, including pulmonary edema. It's all over the body, including the lungs. Do we breathe very well when there's fluid in our lungs? Not at all. Is it something that we can tap with a needle and remove? No, not at all. Okay, it's widespread throughout the lung parenchyma in that case. All right. So this relative hypovolemia means that our vital organs, such as the kidney that we see here, has a reduction in blood pressure. And the kidneys are not being perfused, and all our vital organs are not being perfused well during a distributive shock. And in addition to this widespread vasodilation, we have a reduction in systemic vascular resistance. Now, we just explained that concept earlier. Anytime the vessels dilate, we decrease systemic vascular resistance. Okay, there's lower blood pressure. There's a relative hypovolemia. There's a reduction in systemic vascular resistance. Now, we can intervene and give the patient fluid therapy. Okay, the heart usually compensates by increasing the heart rate and the contractility. Okay, although this may not be enough. So, of course, with a relative hypovolemia, a decrease in blood pressure, a decrease in perfusion, the heart's natural response is to beat faster and stronger to try to get more oxygenated blood throughout the body. Now, the cause of sepsis, it begins with septicemia. That is a pathogen in the bloodstream. If it's a bacteremia, the bacteria produce toxins in the bloodstream, which also lead to this sepsis. We already said that it's most often gram-positive infections, but it could be gram-negative as well. If it's a gram-negative sepsis, the incidence of the mortality rate increases. Okay, so greatly increased incidence of gram-negative sepsis, we are seeing that, and it has a high mortality rate associated with it, even if we are treating that patient. We also have see more gram-negative type of sepsis with the fact that we do more and more invasive procedures in the hospitals. We also are treating immunosuppressed patients, and also with the antimicrobial resistance that has developed. So all of these things have contributed to the fact that we do see more gram-negative septicemia than before. Now, there's many different ways in which the organisms or pathogens can enter and the bloodstream and lead to septicemia. Okay, so here are just some examples of the many portals of entry of pathogens or normal bacteria that become pathogenic. The urinary system. So yes, you can have a UTI and then end up with septicemia. Respiratory system. And so I'd like to show a picture with this because this is not uncommon at all for patients who develop a respiratory infection, especially pneumonia. So if you have a patient who has pneumonia, it's very easy for that organism to get into the bloodstream. All you have to do is recall the anatomy of the lungs, and surrounding all those little delicate alveoli are the capillaries. So it's not a big leap to get from a lung infection to septicemia. And certainly we can have it even gastrointestinal infections can lead to septicemia, skin infections, especially we see this a lot today with our community-acquired MRSA skin infections that can lead to septicemia and onto septic shock. And even female reproductive system infections can also lead to septicemia. This slide shows some sites of infection and septic shock. Now, septic shock usually starts suddenly. The drop in a patient's blood pressure may be catastrophic. He or she may be disoriented, confused, delirious, or comatose. A patient in septic shock breathes rapidly. The blood pressure is low. They have a fever, and the pulse is fast as well. So we need to suspect that a patient is in septic shock when they are already infected and they suddenly become severely ill and hypotensive. The source of the infection can be, as we see in the slide, peritonitis, septic abortions, infected burns, the transfusion of infected blood, and I have seen that occur with very terrible outcomes, and instrumentation of an infected bladder, or the infection could be hidden and make the diagnosis a little more difficult. Okay, so I want to go ahead and mention here before we move on to the next slide is that a first-line therapy for septic shock is the use of vasoactive medications. And I want to give you two examples, the first of which is dopamine, okay? And the other one is norepinephrine. But I want to take this time to talk more specifically about dopamine. I doubt that I will give you a question on dopamine, but you will definitely hear it in the hospital, and it is some knowledge that, that you should have going into the hospital. So when you hear it, especially in the ICUs, you will hear it. You'll understand what they're talking about. Okay, so with dopamine, we give different doses. And because different doses have a different effect on the body, I'm going to go through 3 different levels or doses of dopamine. The low level dosages of dopamine, and that would include, you don't have to memorize it, 0.5 to 5 micrograms per kilogram per minute. Low doses such as this cause vasodilation, especially of the renal vasculature. So if you want to increase perfusion to the kidneys, you would want to administer a low dose dopamine. Now, you could receive orders to give an intermediate dose. Intermediate doses would include 5 to 10 micrograms per kilogram per minute. And these result in an increase in myocardial contractility. Okay, so you see it's dose dependent on the effect that you can expect. So an intermediate dose of dopamine leads to increased myocardial contractility and therefore an increase in cardiac output. Now, if it's high dose dopamine, greater than 10 micrograms per kilogram per minute, this dosage leads to peripheral vasoconstriction by acting on the alpha receptors. Okay, so remember all of that widespread vasodilation that occurs in shock, in a distributive shock. We can counteract that with a high dose dopamine because it causes peripheral vasoconstriction. By doing that, you are clamping down on the vasculature and increasing the blood pressure. Yes, you are increasing systemic vascular resistance as well, but the whole point is elevating that blood pressure. Risk factors for septic shock include hospitalization, debilitating chronic illnesses, poor nutritional status, invasive procedures or surgery, older adults, immunocompromised patients, and then we also had, especially more in the past, but improper tampon use has led to toxic shock syndrome, which is a type of septic shock. And that's where bacteria can enter the bloodstream. Bacteremia can result from the use of tampons. So prevention is key. We need to watch for early signs of sepsis. Anytime the very young and the very old are sick, we need to be monitoring and looking for these signs of sepsis. So if an infant has an infectious process, that needs to be on the top of our mind, especially our patients with cancer. They're immunocompromised, especially if they're on chemotherapy. That knocks their white cell count down very low. They're worse than neutropenic. And the same with radiation therapy. So these two population of patients, especially because, well, for so many reasons I could go into, but needless to say, infants can't express what they're feeling. So you have to be very astute in your assessments of these patients. And neutropenic patients aren't going to present with clear-cut signs of sepsis. They may not even spike a fever to give you a clue that there's an infection, as neutropenic patients frequently do. So there's a lot of things to think about in terms of assessment of our different patient populations. It's very important to prevent sepsis by having immunizations done. We need to get our vaccines against certain organisms, especially the ones that cause pneumonia, because there's a high rate of septic shock that results from pneumonia. And of course, it's always important to use good hand hygiene. Remember, it is friction and running water that rinses the suds with the bacteria off of your hands. It is not the temperature of the water. It is all about the friction making the suds so you can rinse the bacteria off of your hands. And always using aseptic technique when you're caring for patients. Okay, that means you don't want to touch. You want to wipe with alcohol. You don't want to touch it and with your fingers. We want to use good aseptic technique, and especially when we're caring for those peripheral IVs, any type of lines that are invasive, any catheters, all of that, following good protocol. We don't want to keep any line unnecessarily for prolonged periods within our patient's vasculature. So always follow good aseptic technique. And if you're not familiar with that, please go back and refer to your textbook and learn and know what aseptic technique refers to. Okay, so let's talk about some of the signs and symptoms of sepsis. beginning with fever. While you can have just the opposite and low temperatures, that is not the most common, but we certainly cannot exclude sepsis simply because a patient does not have fever, because sometimes they present as just the opposite, which is hypothermia. But in general, it's fever. We see with fever that patients become tachycardic, remember. They also breathe faster. We have tachypnea. There's peripheral vasodilation. We have mental status changes. Make that connection between perfusion to the cerebral hemispheres and changes in level of consciousness. Always remember, first we see changes in restlessness, then agitation, confusion, etc. Okay. Other signs and symptoms of sepsis is the fact that they're now in septic shock with the low blood pressures. Okay. We need to look at their lab results. This is part of your assessment as well. We're going to look for any abnormals in their CBC, their complete blood count. We're going to look for coagulation studies, any of their clotting factors that could be prolonged, our PT, PTT, and others. We look at their liver enzymes, and especially the C-reactive protein, the erythrocyte sedimentation rate, or ESR, and our BUN to creatinine ratio, lactic acid, and procalcitonin. So we will go through some of these lab results here as they pertain particularly to sepsis, our sepsis patients. Okay. All right, the first one we're going to look at is the C-reactive protein. It is an inflammatory marker. It is also described as an acute phase reactant. In other words, the CRP level will rise in response to inflammation. The C-reactive protein is not a specific test. It's a very general test, but it can certainly support and point a diagnostician in that direction of sepsis. Okay, so if the CRP is elevated, there is inflammation somewhere in the body, and there's also an acute condition occurring in this body. Okay, other acute phase reactants will include your ESR and also the platelet levels. Okay, platelet counts are important here too. Okay, so this slide is going to talk about the erythrocyte sedimentation rate, or ESR. This too is a general marker of inflammation. Okay. The ESR is a hematology test. That's the lab department that will run the test. Again, it is non-specific. In other words, it's very generalized. It means that there is inflammation when elevated somewhere in the body. Okay. It's considered markedly increased if it's over 100 millimeters per hour. The most likely common cause of an elevated SED rate is sepsis or infection. Okay. The next marker is procalcitonin. This is the most common marker used to evaluate SIRS, or a systemic inflammatory response to an infectious agent. It's routinely used both for diagnosis, for predicting outcomes, and monitoring patients who have acute sepsis. Okay, so it's not like you only do it one time and that's it. You may do a serial readings to find out if the procalcitonin is going up or coming down, for all we know. But we definitely will use it to monitor the patient's progress throughout their treatment. So it's useful as an early marker for detection of bacteremia in febrile neutropenia. It is much better diagnostic value than the CRP. Remember, CRP and the SED rate are both very general. This has more diagnostic value. Conditions associated with an elevated procalcitonin level, which is greater than 2 nanograms per ml, include the following: bacterial sepsis, severe localized bacterial infection, for example, pneumonia or meningitis or peritonitis, and severe non-infectious inflammatory stimuli, such as major burns, severe trauma, multiple organ failure, and major surgeries. So you can also have severe inflammation as a result of non-infectious reasons. But greater than 2 is your marker there. That's going to indicate that you're probably looking at a bacterial sepsis or a bacterial infection. Here we go, just as a diagram or picture to help you see that the level of procalcitonin is important for diagnosis and monitoring of our patient. When it's low, it indicates that there's not likely to be a systemic infection. Between the level of 0.5 and 2, we see that it could be significant, but moderate systemic inflammatory response and sepsis is likely. So it's still not a good result if it falls in that range, because you could still likely do have sepsis. But greater than 2, we're talking severe sepsis. Okay, severe systemic inflammatory response is the most likely cause due to infection or sepsis. And there is a high risk when you have these elevated procalcitonin levels of developing organ dysfunction. Okay. Greater than 10, this is important systemic inflammatory response. It's almost exclusively due to severe bacterial sepsis or septic shock. So you see that the level does matter in terms of what we're looking at and how we're going to treat this patient. Signs and symptoms of septic shock vary. We have 2 phases of septic shock. So of all the 3 distributive shocks, septic shock is distinguished in the fact that it has 2 different phases. The early phase or warm phase is the patient demonstrates warm, flushed skin and likely has high fever and chills. Okay. The body is trying to compensate for the low blood pressure. In fact, we may not even notice that the blood pressure is all that low. It may seem pretty normal, but it could be low. But the fact is that the body is working to compensate for the low blood pressure. And we'll talk about all those mechanisms later. But it's keeping the blood pressure either normal or on the hypovolemic side, a little bit of low blood pressure, but it's not severe. Then we have the late septic shock or cold phase. Now look here, the skin is described as being cold and moist, or we could call that cold and clammy, because the whole point of septic shock or circulatory collapse is that we don't get peripheral perfusion. We don't get perfusion anywhere in the body. The skin is reflects that by becoming cold and moist, part of your assessment. At this point, the compensatory mechanisms are no longer working. The patient is definitely hypovolemic, okay, or hypotensive at this point. They're not putting out much urine because the kidneys are not being perfused well. We can see changes in mental status because we're having poor perfusion to the brain. Okay. And there can be death that results in the cold phase because of respiratory, cardiac, or renal failure. Let's see. And this phase, you may see that the pulses are rapid, weak, and thready. Okay, that's quite different. Now, I do want you to add one other thing to this list. And let's go back to the warm septic shock phase. Add there that the patient is typically alert and anxious. Okay? But compare that to the late or cold phase. There is a decrease in level of consciousness here. Okay. So we need to treat the underlying cause, and we do that with IV fluid replacement. And by that I mean we will use crystalloid infusions. That means, what do we mean by crystalloid? Normal saline or lactated ringers. Those are the two examples for crystalloid infusions. We also will supplement that with some colloid infusions, which hopefully we'll talk about later, in terms of trying to bump up that blood pressure and pull fluids into the intravascular space. We also will treat the patient with diuretics, vasopressors like dopamine or norepinephrine, and make sure to remove and replace any invasive devices that may be the source of the infection. With septic shock, we have this lovely diagram. Let's go over it. The etiologic agent, that means the organism that is causing the infection and the sepsis, could be bacteria, could be fungal, could be viral or protozoan, and even rickettsia as well. So there's many different pathogens that can lead to septic shock. Remember that sepsis is characterized by a systemic inflammatory response, or SIRS, to an infective insult. Okay, insult, vascular injury, so that can also be described as an infective insult. The inflammatory response results in systemic vasodilation. And we see here the release of mediators of inflammation. Okay, so go back to that beautiful picture where we had the cytokine storm. The cytokines are mediators of inflammation, and here are some examples listed on this diagram. You've probably heard of some of these in the past, especially interleukins, leukotrienes, and interferon. I wouldn't be surprised if you haven't heard of those at some point in your studies. So those are all examples of cytokines, or, as we said, mediators of inflammation. The inflammatory response results in hypotension, increased cardiac output, and eventually reduced oxygen extraction by the tissues. The key pathological features driving this process are abnormalities of endothelial function and disordered coagulation homeostasis. These result in the release of a variety of cytokines and tissue factors, an activation of the clotting cascade, and a reduction in the natural inhibitors of clotting. Once triggered, the downward spiral of severe sepsis is believed to be independent of the underlying infectious disease process. The combination of increased thrombosis and reduced fibrinolysis leads to disturbed microcirculatory blood flow, microcirculatory ischemia, and multiple organ dysfunction, and eventually multiple organ failure. So we also see on multiple organ dysfunction is written as capital MODS, and multiple organ failure is represented as MOF, capital letters. Okay, we also see the signs and symptoms of septic shock listed here in general, which we've already discussed. We've discovered that early aggressive therapy improves patient outcomes. Okay, this is where interdisciplinary collaboration improves patient outcomes. We need everybody in the healthcare team involved if we want this patient to survive, if it's even possible. But we have to have the infectious disease doctors there, ID, infectious disease. We have phlebotomists for drawing blood samples, but we also have, it's not even represented here, are the laboratory technologists who are performing these tests, diagnostics in the laboratory. Okay, we want to know the procalcitonin level. Who's going to give it to us but the medical technologist? Okay, so we work very closely with them. Respiratory therapists, especially if our patient has pneumonia and a respiratory infection. And also, depending on the population that we're dealing with here, is this a pediatric patient or is this an elderly or older adult? That may mean that we need to be involving the gerontologist or the pediatrician in the care of that patient. So let's take a glimpse, an overview of this process of septic shock. How do we get there? Okay, so we talked about SIRS, and SIRS stands for Systemic Inflammatory Response Syndrome. This is systemic because it's the whole body that's involved in an inflammatory process. This leads to an acute critical illness. Now, we will then say that the patient is in sepsis or has sepsis when there is SIRS. SIRS is present, but now it results from an infection. In fact, we know what organism is causing this response. Okay, so if we can now identify the organism that's causing the SIRS, then we now can say that the patient has sepsis. And it can occur as a complication of any infection. Severe sepsis is sepsis, but it's associated with acute organ failure. So this is going another step further. We have sepsis, but now we can say that the patient has severe sepsis, meaning that it is associated with an acute organ failure. Septic shock is when the patient now has a persistently low mean arterial pressure. Not only do they have a low blood pressure, it's that it's persistent even or despite fluid resuscitation. Okay, so the septic shock, it meets certain criteria when you say a patient has septic shock. Unlike severe sepsis, septic shock patients, unlike severe sepsis where patients may experience hypoperfusion or hypotension, septic shock is characterized by both of these symptoms despite fluid resuscitation. So that's why I show you the crystalloid lactated ringers in this picture. Because when we talk about fluid resuscitation, that's what we're talking about. So despite the fact that we give them large volumes of a crystalloid and in an attempt to fluid resuscitate, they still have low blood pressure and they still are not perfusing their tissues. Septic shock results from overwhelming infection. So let's go even one step further. When a patient has a septic shock, the cardiovascular systems are compromised And acute respiratory distress syndrome, or ARDS, can occur when the capillaries are damaged and begin to leak. People can also suffer from acute renal failure, elevated liver enzymes, and jaundice, and various skin disorders, from petechiae and purpura to generalized erythroderma. Research has shown that the most common complication associated with septic shock is renal failure, about 50%, followed by disseminated intravascular coagulation, or DIC, at 38%, and ARDS being the third most common complication at 18%. The next stage would be called refractory septic shock, and this refers to persistently low mean arterial blood pressure despite vasopressor therapy and fluid resuscitation. Okay, so typically in our treatment of septic shock, we like to give fluid resuscitation and then treat the patient with vasopressor therapy. Would be, for an example, would be such as dopamine. High doses of dopamine would cause that vasoconstriction. So one thing I want to mention here, because you do see nursing questions like this, it's very important that before you give a patient a vasopressor, that you make sure that they have fluids on board. Because the whole idea behind vasopressors is that they clamp down on the vasculature. If you clamp down on an empty vessel, you are not going to raise the blood pressure, which is the whole point of it. Okay, so you have to fill the tank. That's what I always say. Fill the tank first, and then you can give the vasopressor and clamp down on the vasculature. This is the only way that you're going to get the blood pressure up. But refractory septic shock is the fact that you have done all of those things. You have done the fluid resuscitation, you have done the vasopressor therapy, and they still have a low blood pressure despite all of our efforts.